trip to India, and it's been really very exciting. So I'm going to speak about how to prevent and treat recurrence. Recurrence is more commonly in fleshy pterygium, those with higher vertical heights, and with older techniques of removal, such as the Bayer's Clara techniques, which shows up to 25% more increase in recurrence than if you do an autoconjunctival graft. So if you have an atrophic pterygium and you can see the episcleral vessels and it's quiet, leave alone. So let the sleeping tiger sleep, because otherwise it can come back with a vengeance. So when do we remove pterygium? If it's affecting the visual axis, or if it is progressive, or if you have astigmatism or any restriction of eye movement, or even cosmetic for the patient's request. So this is the gold standard technique of removal of pterygium. So this is here we cut the pterygium head and neck, and we have to really extend very much and remove all the fibrovascular tissue. It's not enough to remove the head and neck. Then we remove a very thin layer of autoconjunctival graft, and we seal it with tissue glue. So we put the thick part of the glue on the back of the conjunctival graft and the thin in the bed, and then with two tying forceps we move the conjunctival graft to the bed and make sure we stick it also to the remaining host conjunctiva. We can still use fibrin glue to glue also the area where we've taken the autoconjunctival graft, and with this technique there is no sutures, there is no time in removing sutures, much less in irritation from the needles from the suture, and much less recurrence. You can potentially put mitomycin C 0.04% if they are African race or if there are recurrence. You see, very important to also glue the edge of the host conjunctiva to the autoconjunctival graft. So when do you use amniotic membrane? We use amniotic membrane very rarely in pterygium surgery, only if you have a very big epithelial defect. If you have, for instance, a large pterygium with a nasal and a temporal head, and it is recommended now that even if you have to use amniotic membrane, you better use a small part of autoconjunctival graft and stick it on top of the amnion so that you don't leave a large bare area, because it's a much higher recurrence rate. And this is a patient example of a patient where I had to use amniotic membrane, and you can see here the patient 2 weeks after, and then within a month the patient had a recurrence. So in 2017 there was a Cochrane review comparing conjunctival autograft with amniotic membrane transplantation, and in 20 randomized controlled trials showed that in primary pterygium at 6 months the recurrence rate of conjunctival autograft is about up to 16.7%, while with amniotic membrane it is much higher, up to 42.3%. And if you are doing a recurrent pterygium and using an amniotic autoconjunctival graft, you reduce the recurrence rate by 55% than if you use an amniotic membrane. So clearly, huge difference between using an autoconjunctival graft or an amniotic membrane. And now, fibrin glue we use now routinely in the UK and most Western countries, although it is a little bit expensive, but you can use it for many patients. It is easier, very short surgical time, and it has been documented that it shows less recurrence. Some people do use autologous blood instead of fibrin glue, and that has been effective. However, the recurrence rate is still higher with autologous blood than with fibrin glue, but it is cheaper, and there is a higher risk of displacement or loss of the graft. Up to now, we've never lost a graft when using fibrin glue. And this is the healing of the autoconjunctival graft. This has been published, and you can see here there is a reperfusion injury. So there is a swelling of the graft in the first few days after you put the graft in with glue, and you can see areas of hemorrhages, areas of widening of the blood vessels, areas of ischemia, but eventually this all settles down. And these are examples of the patients with 1 week. Sometimes you have retraction a little bit, and you don't want this, but it usually even settles down. And you saw even atrophic areas in the graft like this. We don't know whether this will affect the recurrence rate or not, but so far we've not had any problems with the autoconjunctival graft. People have tried to use limbal stem cell transplantation in pterygium surgery. In our opinion, this is not necessary because you've got the rest of the stem cells which are working, and even when you do stem cell transplantation, you need only 2 clock hours to repopulate the whole surface. So there is really no need to disturb the limbus in autoconj graft. There was a paper in 2008 published by a group from Australia which showed this perfect for pterygium, where they do extensive excision of pterygium up to even remodeling the plica, and the recurrence rate is very, very low, up to 1.6% after 1 year, which is really quite remarkable. So adjuvant, we do use periocular and intraoperative MMC. We don't like intraoperative MMC. We have to wash it very well. We can use 0.02 to 0.4%, 5 minutes. And it's very important to put it under the conjunctival edge, not just only on the sclera, and we wash it very carefully. But we don't like to inject it preoperative. We use it intraoperative. We don't like to inject it preoperative because there has been reports of scleral melts and ciliary shutdown with the use of perioperative MMC. However, we do use very much other topical anti-VEGFs and 5-FU, which is the gold standard technique now that we use in recurrence, and it's very good to reduce the fibrosis as well as the angiogenesis. We've published this paper that we treat the primary pterygium actually with injections of 5-FU even before we think of doing the surgery. It arrests the progression. Sometimes patients will come and say it's cosmetically acceptable now, we don't need the pterygium to be removed, and if you have to remove it, actually you get much less bleeding, much less need to hook the medial rectus, so it has a lot of advantages, and you can see here this patient's pre and post, and the ones we've taken out after multiple injections of 5-FU showed that reduce of all anti-angiogenic and antifibrotic agents in the tissue. So how do we treat recurrence? First, it is very important to recognize conjunctival recurrence. So you can see the redness and inflammation vascularization here, which is telling you that there is a start of a conjunctival recurrence. And it can rarely come from under the autoconj graft, but usually in the back or at the edges from here and there. And it's very important to treat the patient at this stage and not to wait at a much bigger stage. And this is, you don't really want to get to this stage before you start treating your recurrence. And this is a patient who had 5th time recurrence. Our standard protocol now is injection of 5-FU at the slit lamps, about 0.1 to 0.2 mil of 2.5 milligrams per mil 5-fluorouracil under the conjunctiva, and your patients usually need about 4 doses and they settle down completely, as in this patient. Now that patient, they've tried to do many operations for, even did a stem cell localized transplantation, but he had massive recurrence with fibrosis and with restriction of movement. But once we've started doing this 5-FU at the slit lamp, we brought the patient back, operated on the patient, and even put these stay sutures to reform the fornix. And then, because he had such a very strong scarring effect, you can see here very large autoconj graft, but eventually ended up with granuloma. And we knew that patient will have a recurrence. So when he had his recurrence, we started giving him injections of 5-FU, and he settled completely, as you can see here, with 4 doses of subconj 5-fluorouracil. And his son came with the same problem. Again, he had 3 injections of 5-fluorouracil and settled completely. His recurrence settled completely. And you can see here. So we published that. We had 15 eyes of 14 patients, and since that paper, we've done many more where we injected the 5-FU intralesion at the slit lamp repeatedly every week, and we give steroids in between. And in those 12 eyes, one patient only needed 8 injections, but most of them needed less than 3 injections, and 93% showed clinical improvement and regression and arrest of the recurrence. So in summary, medical treatment for primary pterygium with intralesional injection of 5-FU is an option to reduce the vascularity and thinning out of the pterygium. You may not even need to do it, and if you do it, the surgery is much easier. The gold standard technique for removal of pterygiums is excision with the autoconjunctival graft. It is very important to recognize and treat conjunctival recurrence before it comes on the cornea, because it's always been known in the past that recurrence means when the pterygium comes back on the cornea, but you really don't want to wait that long and you want to catch it early. And 5-FU has been very effective in managing recurrence with we've not had any complications reported from it. So as Professor Dua always tells me, there is nothing new under the sun, but the sun is constantly shedding new lights on new objects. Thank you.
Thank you so much, Dr. Syed, for that wonderful talk. I would like to know from you, do you regularly use mitomycin C in cases of primary pterygia? If you see a very fleshy pterygium, do you have specific indications where you'd like to use intraoperative mitomycin C?
Well, we don't use it because we have the Caucasian patients in most of them. We don't use it in primary pterygium unless unless it's Africa, Caribbean. There are other risk factors. The patient has a recurrence, then we use. But primary pterygiums, we don't use 5FU.
Yeah, so I think I completely agree with you. Just a good meticulous subconjunctival dissection of all the tissue actually helps in preventing recurrence, and that